Hi, my name is Brad Siff. I'm the founder and president of BioWave. I'd like to welcome all of you to our monthly webinar. I'm very pleased to introduce our guest lecturer for this month, Dr. Amir Bahreman, and he is head of the Neurological and Pain Institute. And his presentation is titled Effective Pain Relief for Patients, High Frequency Percutaneous Neurostimulation, BioWavePENS. And before I turn it over, I just want to remind everybody that following this presentation, we will have a live Q&A section with Dr. Bahreman and myself, and you can add questions through the little Q&A box at the bottom of your screen. So with that, I'd like to turn this over to Amir. Thank you very much.
Good afternoon. Thank you so much for this opportunity to talk about nervous stimulation, pain in general, and more specifically about BioWave technology. Let me start with a little bit with my background and myself. In a Neurological and Pain Institute, we are two providers, myself and a nurse practitioner. We are currently having 3 offices throughout San Diego County. We are seeing a variety of cases, a variety of insurances, including Medicare, Medi-Cal, PPO, HMOs, and also personal injury. Based on my background and my fellowship training and also my interest, we have focused on pain from a spinal and peripheral nerve basically etiologies. We are working with a big number of surgeons, orthopedic surgeons, and spine surgeons in San Diego. We are very focused on the evaluation and management of the pain, the spinal pain or peripheral pain, as I mentioned. We do perform a big number of electrodiagnostic medicine for evaluation of the pain. We have been seeing patients with radiculopathy or pain from a spinal origin, either caused by injury or degenerative processes. Very common name, we call it radiculopathy, as you know. And also we have been focusing on peripheral neuropathy, which is involvement of the peripheral nerve due to a variety of etiologies, including diabetes or etc. In 2017, if I'm not mistaken, it was first time I got introduced to high-frequency nerve stimulation. And we started that product and device purely for diabetic neuropathy. And later on, about 4 years ago, if I'm not mistaken, we started using BioWavePENS for our cases and patients. There is nothing to say but great things about PENS BioWave regarding patient satisfaction, response, and overall changing the quality of pain in my experience. We have had more than 1,500, if not 2,000, combined sessions of treatment in the past 4 years. And I don't have any specific number about the outcome improvement, but I can say easily 80% of my patients been very satisfied and happy with the treatment. When you do search about high frequency nerve stimulation in main resources and websites such as PubMed, you can see more than 5,000 articles come up, more than 5,000. And you can see that this concept of nerve stimulation is not new. It's been around for many, many years and probably decades. So we started from the traditional part, nerve stimulation, TENS unit, and then we evolved to percutaneous technology or PENS. And after that, we got to this product at this point called BioWavePENS unit. So let me talk about the pens and also BioWave pens a little bit more specifically. As you know, we have different pens devices, but only FDA cleared is BioWave pens. Basically, it's very simple to use. There is no need for programming. The device is very user friendly, and it's the only big difference of this technology is the wires and electrodes that we use for stimulation, which an array of the small needles I'm going to mention about later. Interestingly, this concept works on nociceptive and neuropathic pain. As you know, there are two different types of the pain: nociceptive pain, which are coming from injury or damage to organs such as tendon, muscles, bone, and also we have, in contrast, a neuropathic pain, which is just purely coming from involvement of a nerve. Overall, this strategy and device has a very much better efficacy and also longer carryover, which at times can go to 72 hours following 30 minutes of treatment. So what are the indications? I have not seen any specific, or let's put it this way, I can start this treatment at any level of my evaluation and assessment. But usually we would like to have a conservative measure done for the patient, usually 6 to 8 weeks, 4 to 6 weeks of conservative therapy, including NSAIDs and routine medication, physical therapy, and chiro, and sometimes acupuncture if possible. Then from there we can start thinking about this process, using it in our management plan. I don't use this for low level of pain, and it's indicated to use when the pain level is 4 to 8 based on the visual score. Indications are spine-related and musculoskeletal pain, which I'm going to mention about it later. However, I specifically have used this for neuropathic, for a specific pain involvement of a territory of a specific nerve. Usually, we are seeing a different type of patients with different desires, different priorities, and fears. Not everybody is willing to have epidural injection. Not everybody is willing to have surgery. And therefore, when we are getting to those kind of situations, PENS treatment, especially BioWave, can have a very special place. Cost is always been a problem in the healthcare. And definitely, it's a matter of consideration. The cost of this treatment considerably lower than other interventional and invasive procedures. So about the contraindications, pacemaker and patients prone to seizures. Basically, these are the people we probably should avoid of using this device. I heard about pregnancy, but I don't think it's a real contraindication. I personally prefer not to put the electrodes on the trunk and the neck of the patient pregnant. However, I don't have any problem using the device when there is a limb involvement or distal limb, like a knee or hand involvement. About the protocol, it's super easy and user-friendly. Usually, we recommend 4 to 6 treatments in a period of 2 or 3 weeks. Ideal situations is 2 times a week. And basically, I can apply the device, a nurse practitioner or medical assistant apply the device. It's not something that a physician has to do it only. So let's talk about the kind of mechanism of action and how it works, and what is the wave we are talking about. Okay, so when we go back to frequency and how we're going to categorize high frequency versus low frequency, the cutoff point is around 200. So its frequencies between 1 to 180 or 200 are usually called low frequency, and above that is high frequency nerve stimulation. So obviously, you know about, the matter of stimulation and frequency and devices such as TENS. But one thing is this, the penetration of the wave and the energy to the tissues beneath the stimulation area, it's a big deal for low frequency nerve stimulation such as TENS. Usually doesn't matter what kind of wave we have, this signal doesn't penetrate enough to put some effect on the nerve generating areas. PENS, PNS and S, or spinal cord stimulator or peripheral nerve stimulators, are also devices that can be closed and can be placed very close to the nerve, but obviously they have their pros and cons. They're invasive, and it's a topic beyond the topic of the spectrum of this discussion. So let's go to the PENS and talk about how it works. So basically, we are having two areas of a stimulation at the same time. So two electrodes are going to be placed exactly on the top of the area that we are believing are source of the pain. So these two electrodes are working at the same time, alternatively, with the same frequency almost, and there are two independent electrodes at the same time, basically. As a result of this, we are able to see 3 to 5 inch of diameter of area totally beneath of this stimulation area. Is like a dome. And this is very unique about this device, which I try to mention about it also later. So how it works, there are different mechanism of action mentioned and hypothesized. One of the major mechanism of action is the conduction block. Basically, with this magnetic field, which is with the big area, sometimes 3 to 0.5 diameter, exactly beneath of the electrodes, we are able to totally block the nociceptive and neuropathic generators. Obviously, we know C fibers are main fibers transferring and transmitting the pain signals. The transfer and transmission happens not just the nerve cell, in all cells by a sodium potassium transportation throughout the cell membrane. Basically, we are having a dipole on the cell membrane at any given time, which makes a magnetic field, very, very small magnetic field. With this placement of this BioWave and this electrode, we make a bigger and a stronger magnetic field, basically to hyperpolarize this smaller one that is going to interrupt the transfer and transmission of pain. Most of the patients, when we start the treatment, in about 5 minutes, they feel numbness in the area, and it's hypothesized that is activation of the delta fibers. There is a very kind of unique about this strategy and device, that most of the patients, for about sometimes hours and sometimes about 72 hours following the treatment, they feel numbness, and that is because of afferent stimulation hypotheses, which we know that is a very well-known in vivo hypothesis. There are other mechanisms of action we can see which are not related directly to the nerve, but they are including hyperemia and increase in the circulation and also some kind of direct effect of the nerve and the other structures underneath of the stimulation area. So what is unique about this technology is the electrodes. So instead of a routine or a conventional PENS stimulation, we are seeing a round array of electrodes. We call it PEA, or percutaneous electrode array. So usually, instead of having one needle as a traditional kind of PENS, we are having 1,014 needles placed very uniquely in a 2.5 diameter. And with this PEA, or percutaneous electrode array, we are able to make that magnetic field that I just discussed around and on top of the pain area. When you put the electrode on the patient's body, they sometimes feel like a Velcro. So when you compare pens with the BioWave pens with the conventional pens, definitely you can see that the electrode, the way of we stimulate the nerves is totally different. Instead of having a long needle, they are a electrode, like an array of electrodes. In the regular or traditional pens or conventional pens, the needle is the top of the tip of the needle is the center of the stimulation. However, with this system, the whole array is going to start stimulation and make a magnetic field. The size of this area, the treated area, is totally different. And again, in the conventional pens, it's very limited to the tip of the needle. However, in BioWave pens, it can be as 3.5 inches of dome that I told you about. So in the conventional pens, it has the placement has to be very accurate, otherwise we're going to miss it. However, this much accuracy is not needed in the BioWave pens, and more importantly, the response is definitely more lucrative and better in a BioWave. As a summary, this device has been safe, convenient to use, and without any significant restriction. Overall, 85% of the patient have been having positive results. 40 to 60% of the patient have a reduction in their visual pain score. The result can last up to 72 hours, as we mentioned before. They experienced increased range of motion and reduction in stiffness, and also a significant reduction in the amount of medication and anti-pain medication they use. There is one study done in Chicago, Rush University Medical Center, about the knee pain. They had 70 patients randomized to live and sham group. They had chronic pain more than 3 months, and their visual pain score 3 out of 10 at least. So they placed the electrodes and they did the treatment as per protocol for 30 minutes. The results show that significant difference in their PID score versus sham, and also majority of the patient, they were satisfied and felt better with the treatment. This study was published in a journal Orthopedics in 2007, and again it showed significant reduction in the pain level and patient satisfaction, and also the VOMAC score after 48 hours from the treatment. One thing I have learned in my practice, that the placement of the electrode is so important. I always try to categorize the pain as a regional pain or a radicular slash neuropathic pain. So on the slide on the left side, you can see the placement of the two round electrodes. We call them B electrodes. And this is more for the patient who are having non-specific back pain, paraspinal pain with not necessary or typical radicular features. On the right side, you can see the patient that having a pain on the lower back with radiating to the gluteal area and kind of radiculopathy and radicular pain. So you see that one of the electrodes is in the center and the other one is almost around the sciatic nerve. Another scenario is the patient are having a focal injury, either shoulder, knee, or elbow, for instance. You can see the placement of the left electrode. Here in this slide, you can see different type of electrodes. You see the round, smaller one, and a square, a bigger one. And basically, both electrodes are stimulating electrodes or feeder. However, because of the size, you can see two different magnetic field and two different kind of mechanism of action. It's recommended to put the smaller one on the top of the most painful area and the other one which can produce a smaller magnetic field somewhere on the bone for having less discomfort. Body position is important. The electrodes, as I said, the electrode placement, it's very important to be placed correctly and appropriately. Usually the patient is in kind of a sitting position. When you are putting on the electrodes on the neck, head, it's better to be tilted forward in order to have a maximum penetration of those small, tiny electrodes or needle electrodes. On the thoracic and the shoulder, neutral position. And in the knee, usually we like to have a 90-degree position. So the setup is super easy. It's very, again, this device is very user-friendly and the setup is very easy. Usually it takes about a few minutes and a nurse practitioner or medical assistant can do that. Again, we have to figure exactly what we are doing, what kind of pain we are dealing. So we need to make sure that the area of the stimulation is clear for us. We can mark it and then we can put the wires on that. Basically, when you're putting the electrode, you need to put a little more pressure at the beginning. Again, don't forget, this is like a Velcro that they go a little bit inside the skin. So when you do that, when you are done with the placement of the electrodes, then we're going to start patient education about how to adjust the stimulation. Basically, patient runs the show after this part. We give the stimulator to the patient most of the time. It can be sit or it can be placed next to the patient, but most of the time we give it to the patient and we ask them to start based on their comfort level. So in my experience, we start from 14, 15, and we tell the patient that after a few minutes, you might feel more comfort, so you need to go up with the stimulation and to get to the level that you're comfortable. Usually in the first sessions, we don't push it too much. I like to have a very good kind of experience the first session. By usually in 5 minutes, the patient feels some numbness and tingling around the area of stimulation. 10 minutes or 15 minutes into the treatment, most of the patients are able to get to 15-25% intensity, and at 30 minutes, 50%. In my experience, I haven't had any patient about 70%, but I am sure there are patients that can tolerate higher. Most of the patients like to crank it up quicker and faster in order to get the better response. But specifically in the first session, I'm very cautious because I don't want to give them a bad experience. And this slide, you can see kind of the average of the stimulation intensity in different parts. In the knees and ankles, we can have a little bit better intensity. Higher intensity is more tolerated, better tolerated. In the lumbar area, we usually get to the 40%, in the neck to 30%, although I have had more. But overall, minimum intensity level is 15. So this is your starting point, in my opinion. At the end of the session, when you take the electrode off, you can see a round area of pinkish/reddish with few drops of blood sometimes, not always. And this is totally normal. This is because of a specific kind of a structure of those electrodes. We usually clear it with alcohol prep, and then just to swap. We don't need to put a Band-Aid or anything on that. Most of the patients don't have any significant reaction. I have had just one patient, and this is a patient with a severe intractable back pain, has been offered surgery, and also has had multiple epidural injections. So she really needed, and she wanted to try this. We got this treatment started, but after the first session, I had severe reaction at the skin side. But I talked to the patient, she really felt much better and she wanted to continue. So basically, I treated her every time with a topical steroid and also ice pack to just give her some comfort. And she finished two sets of 6 sessions at the end. Very happy with the treatment. We have had cases here, but I'm gonna just go through quickly. This is one of our cases, a 42-year-old gentleman with severe lower back pain. Pain was radiating to the left glute, and with this pain score 8 out of 10. It was relatively severe and kind of a chronic pain. The pain has some radicular features, as you could say. So our placement was in the midline and also in the gluteal region over the sciatic nerve. So the patient started the treatment in 45 minutes. Patient was over 19% intensity. You're asking why 45 minutes? Well, in my office, the standard treatment is 30 minutes. But I have also learned if I can ask the patient to continue treatment for another 15 to 20 minutes, I have seen actually more and better results and more convincing that it's working better in my experience. So we continued the treatment. The patient was very happy. And at the end of the treatment, 6 sessions, the patient had about 50% improvement and a significant reduction in lower back pain and sciatic pain. This is a very interesting patient. We had a case, young man. He was involved in a very high-speed motor vehicle collision. He had a significant whiplash injury with radicular issues. Unfortunately, the patient had a bleeding disorders, which is called hemophilia. I believe you are familiar with this condition. These patients cannot get injections, cannot have surgery unless it's super necessary and life-threatening, then yes. So we couldn't do a lot of things for this patient. I saw the patient after 6 months from the injury. The patient already had considered the treatment, chirophysical therapy, and medication. So we decided to go with this device and treatment. As a matter of fact, it was super, super helpful. The patient was so happy. We reduced the amount of pain and discomfort 70% at the end of the treatment. Very interestingly, when I was taking the electrodes off of the skin, I always was thinking, oh my God, if might be a little problem with the bleed or something, but thank God nothing major happened. And Nothing there. Nothing there was. Just a regular redness. So that was one of our successful cases. And again, as I mentioned, there are a lot of patients either are not willing to have injections or invasive procedures or not qualified for those, including this patient. This is another patient with a back pain. We started the treatment. Again, after finishing the treatment, the patient felt significant increase in mobility and the pain level. In summary, this device, BioWave technology, has shown and has proved its efficacy compared to other percutaneous electric nervous stimulation technologies. A unique feature, or at least one of the unique features of this device, is long and carryover, which can last up to 72 hours from the treatment. It's super user-friendly and easy to use. No programming is needed. And the patient starts and finishes the treatment with maximum comfort. This is very excellent treatment when you are trying to avoid of invasive procedures and treatments.
Amir, thank you very much. That was a great presentation. If you can turn your video and mic back on. So we have the Q&A session now, and if anyone would like to leave a question so that we can answer it live, please go down to the Q&A box on the bottom of your screen and put a question in. Actually, we already have a couple of questions here. So I'm going to start. Amir, the first question we have is, how long does the pain relief typically last after a BioWavePENS session?
Sure. It's very individual. We have seen the different numbers, different kind of time frame and those things. But usually, we in the first 6 to 8 hours, we see is a big change, a significant response. It continues for most of the patients the first day. After that, it fades out and goes down. And usually, we have seen the data, the studies showing that the effect for a big number of patients can continue to up to 72 hours. But what I have seen, when the cumulative effect of this starts, this is going to last, the relief is going to last longer. So the first session, if it's about 10, 12 hours, we are seeing that on the third and fourth and fifth sessions, the patient can go easily to 1 day because the cumulative effect of this treatment is going to start.
That's very typical. We've seen that in many patients anecdotally, and we get that information from many of the clinics we have that are using this technology. The next question that came up here, it's are there particular patients that respond better to BioWavePENS than others? How would you comment on that?
That's a good question. I am a neurologist, so when I'm seeing probably the biggest portion of my patients are pain, nerve-related pain, such as neuropathic pain or radicular pain, so the radiculopathy. We see a lot of patients with a whiplash injury and following the car accident, or also other injuries involving the neck and back. So we are dealing with a mixture of pain pathologies and physiopathologies. My experience, since I'm seeing more radicular pain, I have had very good response. And there are times patients have mixed. So like a whiplash patient, they can have radicular and also a structural pain. And I see the way that we place the electrodes and diagnose the etiology in the first place is very important to have a better outcome.
Okay, thank you.
Sure.
The next question kind of touches on this a little bit, what you just answered, but it has to do with pad placement. It says, where should the pads be placed for optimal results when treating neuropathic pain? It obviously depends what type of neuropathic pain, radicular or not, whatever, but if you could try and take a shot at that.
Absolutely. So this is what we always do. I think the patient is the best doctor too. Always, we know that. So I give them the reference guide, and I kind of joke with them, hey, this is the menu that you have today, and pick what you want. So they look at the reference guide. Actually, the patient can tell us what is the best placement. And they look at the menu, the reference guide, which is fantastic. We're really using it for every patient, especially the first session. And the patient is going to come up after about 2 or 3 minutes of looking at the reference guide, come up with one pattern. And then I'll try to see, to use my information, other information that I have regarding this case. For instance, if the patient has an abnormal cervical spine or lumbar spine, and the pattern can also be radicular. So I try to place something between my way of placement and also patient. So we're going to settle something in between. But most of the times, I would say 90% of the times, the patient are right about the placement. So I'll follow them.
Thank you. What I would just add is that BioWave is very intuitive to use, and generally electrodes are inserted directly over locations of pain. But in the case of a radiculopathy, we want to treat over the origin of the pain in the direction that the pain's radiating. So if here's the spine and the pain's radiating to the right, we'll be over the spine, but just maybe half an inch to the right to capture where those pain signals are coming off the spine. And then the second electrode is typically placed in the most proximal location of pain relative to the spine. Even if the pain's radiating all the way down the leg to the foot, if we can place at the origin and the first location pain presents, that actually will block the radiating pain further down distally. So as you described it, that's kind of exactly how you were describing it, kind of in a different way. But I just wanted to throw that out there for our audience.
Sure. Can I elaborate a quick note here? So as we know, we have 2 sets of electrodes. We have B sets and E sets. For most of the patients that we are seeing in our practice, B electrodes, we are using mainly B electrodes. Why? Because first of all, they are for most of the patients that we are treating, which are neck and back injury. So
Yeah.
those are set for those. They are different with the E sets when we are having a limb or extremity problem. So in the A sets, you can see that there's a smaller one and also a bigger electrode, a rectangle, bigger electrode, which has the less magnetic field. And the smaller one has the maximum magnetic field. So basically, that's the main electrode. So for instance, for tendonitis or for a specific ankle injury or knee injury, we can use those, which is set again, E electrodes or extremity electrodes. And that specific small one is going to be on the center of the pain, on the top of the most painful area. And that also has significant effect. But for the radicular purposes or more muscular pain around the spine, we do B sets. And if it's radicular, I'm going to start with the spine, at the middle of the spine, and I'll travel. I try to put the second electrodes about 5 or 6 inches on the route, basically the route of the nerve, wherever it's going.
Exactly.
Yeah.
I would just make one other comment. The E-set electrodes are typically for a single location of pain, which is typical in the kind of applications that you described on the knee or tendinopathy on an elbow or other part of the body. And the larger rectangular electrode has no needles in it, and so the field underneath is not nearly as strong. And it really acts as a dispersive electrode, and we place that over bony prominence, as you mentioned in your presentation, because it's a more comfortable location to receive the stimulation, and the patient can just turn up the intensity. So what they feel under the percutaneous electrode over the single location of pain, that's what they're limited by, what they feel in that location. So that's kind of that's another way of describing it. But it's exactly as you presented. We have another question here. Are there logistical challenges when scheduling and managing patients during BioWavePEN sessions?
To the best of my knowledge, no, I haven't seen anything specific. This is a very easy and user-friendly device. So we don't have, once the patient gets to the office, we don't have any issue. Of course, we have no-shows, we have other issues than all clinic they have. But when the patient gets to the office, no, the first session is kind of questionable for them, or what's going to happen to them, what kind of experience they're going to have. But the best thing is to explain exactly what they are going through and tell them about the steps and different level of experience they're going to have. As soon as they feel comfortable and they become a more believer in what you told them, then they're going to go through it much more smoothly and easier.
Okay, thank you. Another question that came up here is, are there any adverse events or complications associated with BioWavePENs that you have seen?
I have read about vasovagal effect that has occurred in some offices because, again, don't forget, these are the patients with pain. They are here for pain. And nervous stimulation sometimes can immediately cause a little intensify the pain in different, with different reactions. And that can cause vasovagal reaction and syncope. I've not seen it in my practice. Maybe we start, because we start this very gradually. We always educate the patient. I think education is very important to avoid of some side effects, especially this one. We can see a little blood sometime at the the site of the electrode placement. And we know that this PEA, or a percutaneous electric array, is consisted of 1,014 small, tiny needle. So it's like a Velcro. When they go in, when you pull this off, you might see a tinge of blood there. Sometimes, I mean, it's really nothing. Just wipe it with the alcohol as well. And then basically that's it. Nothing much as a side effect in my experience.
Yeah, it's common, maybe in 50% of the patients, that you'll see half a dozen tiny little drops of blood out of the 1,014 needles, because they do penetrate the epidermis.
Absolutely.
And that's the advantage that electrode has, because you're bypassing the impedance and capacitance, essentially the electrical properties of the skin, right, by having a direct conductive pathway through the skin. Let's see. Another question that came up here: what are some best practices for documenting and keeping records of BioWavePEN sessions?
Well, first of all, before starting the patient, on my progress note, I'll explain very thoroughly and in details about why we are going toward this decision and this device. I like to show at least we have tried a couple of other options, conservative options, such as physical therapy, cryotherapy, and also medical therapy. We get the patients for the PENs in different stages of their journey. It can be at the beginning of this issue and the injury, or it could be at the end after the surgery. So we'll see. But usually, we start this as soon as we see okay, this is the right time and the patient has tried. We don't start this for the mild pain. We have to document about level of the pain in terms of documentation. I like to start from 4, which they call it moderate pain. At the level of 6 of the visual score, that's the level the patient says it's a moderate to severe pain. That's the level 6, which the patient needs, and they use medications. Sometimes not prescribed medicine, but it's over-the-counter medication. So when I see a patient between 4 to 6, that definitely it's a right setup. Then when in terms of documents, so in my progress note, I'm going to explain why I am doing this. When the patient starts the treatment, we have also progress note for the treatment sessions. In that, we explain, okay, all of the patients' demographic, everything, of course, is there, and date, everything. We explain about the placement of the electrodes because of the patient's, the type of pain patient has. We actually have a kind of a schematic things. We show it where we place the electrodes for the patient for that session. Most of the times it stays until the end of the session, which is 6 sessions, but sometimes we change it. Very, very rarely we change the directions and the placement. So, and also we start with the level of the pain for that particular session before and after the treatment. We explain the time of the treatment, and also we write a little bit about the patient's experience from the previous session. So in that sheet of information, we'll kind of wrap up everything a little bit from the past and the previous session to this session.
Thank you very much. That's all I have here in terms of questions. Appreciate your time,
Yes.
and it was a great presentation. And I'd like to remind everybody else who's listening that, check in next month for when we have our next webinar series. So with that, thank you very much.